Hey there, and welcome to our review. We're going to be talking directly from our 7th edition text today, so make sure that you kind of follow along. If you're not in the 7th edition, that's the green book, then you may have to reference back a few pages. But we want to talk to you about what we are looking for you to end Therex 1 knowing and being able to use. And so we're going to start first with mobility, and that is primarily out of chapters 3, 4, and 5. And so one of the things that we started with was understanding the definitions of specific terminology in range of motion, and that was passive range of motion, active assisted range of motion, as well as a self-assisted range of motion. And so let's just kind of be clear. One of the top things that we wanted you to understand was passive was external force. That meant maybe it was manual, maybe it was mechanical, but it meant that something external of the body was doing the motion for you. Another very confusing yet very important term is active assisted versus self-assisted. Active assisted, that was an external source, almost always the therapist, where self-assisted, that meant that you were internally using that active motion, but then you needed a little assistance that you yourself would provide as the patient, right? So we're going to kind of think about that just in terms of the way they are different. And so we'll get a little bit more into that here in just a second. But then also remember what your indications are for each. But most importantly, think about passive range of motion. What are your indications? Well, this was something we could do in the acute inflammatory phase. And so remember, passive is acute. And that's one of the areas that we would do that. It really needs to get out of acute inflammation, more into that controlled motion or moderate protective phase before we begin active range of motion. But then we also wanted you to know, what does passive range of motion not do? And this was a really specific thing throughout chapter 3. We said it does not prevent atrophy because it's not the muscle moving. And we'll kind of talk more about hypertrophy in just a few minutes. But that is not going to prevent atrophy. It's also not going to increase strength or endurance, right? You have to load the tissue, and there's a very specific, think specificity, to the load that has to be there to make endurance or strength happen. And then finally, it's not going to assist in circulation the way that passive range does. So you're going to want to remember those three key aspects of what it does not do. And then we want to give you some examples, or at least remind ourselves of some examples of what a self-assisted range of motion is. And we actually kind of looked at this from the standpoint of, okay, this was the finger ladder, this was a wand, and we kind of identified those as being kind of our bigger self-assisted range of motion. Also, overhead pulleys was a big self-assisted range of motion, even though we really didn't get a chance to participate in that. And then some other things that we kind of went to from there in chapter 3 was the CPM. And I'm going to give you 3 things that you have to take away from CPM. I know you already know how to set the CPM up, but it's really important to me as your Therex teacher to make sure that you know that this is used after surgery. This is not something that we see people using in place of therapy. Almost always this is a part of the therapy, and it's the responsibility of the therapist to know that it's going to be placed on them after therapy, and then it has to be removed it's going to be placed upon the patient after surgery, but then it's going to have to be removed to be put the patient into therapy, right? So we're going to do it that way. Number 2, that rate of that CPM is 1 cycle every 45 seconds. So you're looking at basically less than a cycle per minute, or a full cycle per minute, but it's going to take a little bit of time to do 15 or 20 repetitions. And so we don't really look at it from a repetition standpoint either. What we do is we say they're going to be using this for a duration of time, and what we know is that could be as little as 15 minutes, it could be as much as 24 hours, but that does kind of have some importance, and it's some key areas again that we think you need to know before you leave Therex 1. We then kind of want to look at the next aspect of modality, and that was stretching. So what we're talking about there is forcing motion, right? So how does that differ from passive range of motion? Well, passive range of motion was working within the limits of tissue movement. And so if it starts to stretch or it starts to hurt, then you're no longer doing passive range of motion. So stretching is forcing motion, right? And so we're going to take that tissue, we're going to tighten it, and we're going to add a little bit to it. Now, there were some very specific things that came from that chapter. Number one, there were 4 types of contracture, and you're going to want to remember each one of those 4. So you had a myostatic, a pseudomyostatic, a fibrotic, and a periarticular. And so out of those 4, we gave you some specific definitions. You're going to want to go back to chapter 4 and kind of review those, but those are very key in understanding how we go forward. But also kind of remember that contracture is muscle, and it's almost always an adaptive shortening. It's just, what did it adapt to? Did it adapt to disuse? Did it adapt to surgery? Did it adapt to a neurogenic condition like cerebral palsy? Or did it adapt because of disuse or misuse, like fibrotic does in the form of an adhesion, right? And so you know that those things exist, but go back, reference those key definitions. And then we also talked about the stretch reflex, which was 2 things. It was muscle spindles and Golgi tendon organs. And what do the muscle spindles do? They prohibit motion when they detect length change. And then the other thing is the Golgi tendon organs would come in and say, no, it's okay, let that motion happen. But you do need to be familiar with the stretch reflex, so make sure you're reviewing that. And then, what was the intensity of stretch? Well, it should be somewhat uncomfortable or discomfortable. And so we don't want to feel pain, but we do want to feel a level of uncomfortableness, rather, to just kind of give them some level of understanding of what they should be feeling. But pain is almost always a no-go, so just kind of bear that in mind. Another thing is, what is the duration of stretch? Well, we gave you 2 very specific things. This wasn't really well defined in the book, except for in one area it was, but that was to the well elderly. Let me talk to you though about just the young people going through their stretching. We're going to say that you're going to do it 3 times 30 seconds, right? And that's almost always. Now, if they're well elderly, we're going to take and go off the intensity just a little bit, but take the duration up, right? So this is the first time I'm referencing that inverse relationship of intensity duration, but it's key here. So well elderly, they're going to go 60 seconds, but with less intensity. Right, so you just kind of want to keep those 2 different in your mind. And then we also want to know about modes of stretch. And so that was static stretch, that was PNF stretch, and we're going to talk about that here in just a second. But the modes of stretch most commonly that we use is static stretch. And again, that's 330 seconds or that's 390 seconds with variance of intensity. What's the direction of stretch? Well, this is also very important. So you need to know that the direction of stretch is opposite of the muscle's action, right? So you may want to be saying that throughout the course of your test, especially if you're seeing a stretch question. The direction of stretch is opposite the muscle action. That means if you are stretching the hamstrings, which are traditionally hip extensor knee flexors, you're going to do knee extension, hip flexion. And so it's really critical that you kind of keep that straight in your mind, because you're going to see questions, and even though I know you know the answer, sometimes those words kind of just get in your brain and they mess you up. So make sure you're concentrating on the opposite of the action, and then you should be pretty good. What about PNF stretching? What do you need to know? Well, you need to be able to read through and decipher what a hold relax versus an agonist contract. Remember, a hold relax is we're going to take that muscle, we're going to stretch it, and then we're going to make that muscle contract back against us. An agonist contract is we're going to take that muscle, we're going to stretch it, and then we're going to tell it to basically have the agonist, which is the opposite side, contract and pull that muscle into stretch actively. And so that's kind of a crazy thing to kind of think about, but make sure you kind of go back and review and even try it on yourself, right? And maybe consult some of your peers in the class and think about what it is that you have to do to get that stretch done. All right, so next on our list was joint moves and neural moves. And we really kind of reinforced a couple of key things on joint mobs. Number one, you need to know what your roll, spin, and glide are, and that's kind of the way we do joint mobs. Like, I know a lot of you have participated in patellar joint mobs, right? And so you do a patellar joint mob, you're doing a glide, which is basically just taking the joint and moving it across its surface area, right? And then you need to know what contraindications are, and almost always this is going to be acute inflammation. However, that is ironically contrasted to what we'll teach you in Therex 2, where you can do joint mobs. It's just you don't do like 3s and 4s in the acute phase, you do like 1s and 2s, and we'll kind of get into that, but just kind of be familiar with that big contraindication. But another one too is if they already have hypermobility. If I have a hypermobile shoulder that's dislocating all the time, I don't want to go in there and do a lot of joint mobs, because I'm only going to increase the risk of hyper or dislocation. So next is, what about the grades? So you have grade 1, 2, 3, and 4, and what you have to look at are two things: amplitude, but also you have to look at the range of movement that's going to occur. So like they go small amplitude, large amplitude, large amplitude, small amplitude, but it's about what the range is. So small amplitude, beginning of the range, is a grade 1. Large amplitude in the beginning of the range is a grade 2. Large amplitude out towards but not quite to the end of the range, sometimes maybe, is a grade 3, and a grade 4 is small amplitude all at the end of the range. And hopefully you've done some patellas and you kind of get that now, but you can translate that over. Please be aware you're going to see questions that address the grading specifically to amplitude and range. We want to move now to neural mobilizations, and some of the biggest things there is just for you to understand what those positions look like, right? So we gave you 3 upper extremity, 3 lower extremity. You saw some pictures on that. You can go back and reference the original PowerPoint, and that would probably be your best bet. But think about what should be the upper extremity, lower extremity movements. And then also, is there a spinal position involved? Does the cervical spine move away or towards to make that better or worse? And so just kind of think about that, but definitely key in to the extremity movements so that you have a firm foundation in knowing neuromobilization techniques. We want to now move into stability. Stability was really all focused on resistance exercise, right? And so we're talking about how to get the muscle stronger and have more endurance. And so that's really kind of the thing, is do you have a working definition of strength and endurance? Well, it is the ability of a muscle to generate force. That's strength. But if the ability of that muscle needs to generate force repeatedly, that is where endurance comes in. And so sometimes that gets students a little flustered because they're like, well, aren't I still going to do 8 to 10 reps? Isn't that repeatedly? Yes, and those are known as repetitions, right? But it's, can you go out 15 to 50? That's really kind of the key terminology to repeatedly. Like, we can do a few and we can make it happen, but to do a lot, we're going to have to what? Reduce the load. So here we go with that inverse relationship, and you should be able to work those definitions in. Another definition that I want you to be familiar with is sarcopenia. Sarcopenia was that age-related muscle loss that we are all going to go through. It starts in the mid-30s, and it almost always looks at about 2.5% every year after that, up until your 60s, where it really starts getting bad. But we just need to understand what sarcopenia is, from not necessarily naming it a disease, but rather an adaptation. And that's kind of the walk away I want you to have from it. Another thing that we looked at here were principles, specific principles of resistance exercise, right? So a principle of a college student was that you're going to study and take tests. Well, principles of resistance exercise say, number one, you need to overload tissue. And we'll talk more about that specifically. You need to overload it though. You can't just do what you're used to doing. And then number two is progression. The patient needs to progress. They need to see bigger, more compounding movements so that they continue to have adaptations. Another one was reversibility, and that was you don't lose it, you don't use it, you lose it. And so we know that those are the principles that we will have as a foundation to doing resistance exercise. Another thing that we looked at were what were the concepts of recovery. And if you'll remember, I talked recovery in a couple of different ways. I named it, or I didn't name it, but it is named intersession and intrasession. And there is kind of a caveat here that is frustrating to me about the English language, I suppose. But intersession, I-N-T-E-R, that first one you see there, or that second one that you see there, it sounds a lot like interval, and it makes me want to say, okay, well, that's between sets, like, right? But it's not. It's actually quite the opposite. INTRA is between sets. And then INTER is like between days. And so it would be nice if they would have kind of reversed that, because we use the word interval a lot, and we know from the aerobic chapter that interval means to have a rest period, but it's not quite the way it works, and so you kind of have to reverse it. But you need to know what's appropriate, and this is kind of the biggest thing, what's appropriate rest for an intra-session rest period or recovery period. Well, we need 3 to 4 minutes for the muscle to get back to 90+% of its MVC. So you kind of have to know that as a PTA. You don't want to just rush them through their sets, because they're probably not recovering in time. As far as the intersession, what we look at there is, how many days does it take? And this is kind of what guides us into frequency anyways, but they really need 48 hours of rest between exercise sessions to really recover and be able to return. Although I know that kind of flies in the face of a lot of traditional strength training, especially those people who are doing it 5 or 6 days a week. But this is just what the textbook says. This is a Walgreens perfect world, so don't get too stressed about that. So let's kind of just look at it this way. So we're going to say about 3 to 4 minutes intra-session. We need about 48 hours of inter-session. And again, that guides the frequency model that we'll look at here in a minute. Let's talk about adaptations. What do we see as far as adaptations from resistance exercise? Well, number one, you need to be really engaged with this term hypertrophy. In fact, what we know is hypertrophy is what the adaptation in skeletal muscle will be. It's not hyperplasia, which is more muscle fibers. It's not metaplasia, you're not turning fat into muscle. But it is hypertrophy, meaning you're taking the cell fiber the muscle fiber cells, and you're making them bigger. And most commonly that occurs at the myosin and actin level. And maybe you kind of remember a little bit about how we talked about that, but just definitely know the hypertrophy side is the adaptation. Another adaptation concept that you need to understand is that all muscles have a mixture of fiber types. It's not that the calf muscles are all type 1 or type 2. They're a little bit of both, and what happens is depending on your genetics and your training, you kind of basically build in to having more of type 1 or more of type 2. But type 1 is slow twitch, it's endurance muscle fibers. Type 2 is fast twitch, and there are 2 types of that. We're not worried about you knowing necessarily that, but you need to know that type 1 is slow, type 2 is fast. And you also need to know that there's kind of a mixture of each muscle fiber in every muscle that we know of. Another thing that we know on adaptations is people really need to understand, especially you as a therapist, that intensity is all about loading, and the load will dictate whether they're going to get strength or whether they're going to get endurance. Repetitions are arbitrary, but if you load it more, you're going to get less repetitions, right? And if you load it less, you're going to get more repetitions. And so more repetitions, by virtue of the definition, would lead to endurance. Less repetitions, still under load, a better or greater load is going to mean more strength. And so we do kind of have kind of a set number on that, and we say that between 8 and 12 repetitions, if the load is right and they fatigue to the 12th, then they're probably working at strength. But if they go 15 to 50, which means they're working at a very low load, then they're going to get more endurance. And so we tell you 8 to 12 for strength, we tell you 15 to 50 for endurance, just to give you some really clear boundaries. Now from there we look at this concept of sets and reps and understanding that it should be, and this is a prediction based off of a 1 rep max, but you should see approximately 15 reps at about 60% of your working 1 rep max. And then we should see approximately 10 reps is 75%. And if you get around 5 reps, you're working closer to 90% of your 1 rep max. And so those are some key numbers that we really want you to have as a takeaway, because we feel like even though you're not going to use the 1 rep max, many times it's very handy for you as a therapist to know kind of where you should be working. And so if you kind of consider this between the 10 and 15 mark, you kind of can see what you're doing as far as their max reps range. And so you can kind of work within that. What about exercise order? Well, there was a very concise way of saying how we're going to prescribe exercise, and we told you that you're going to always want to start with big multi-joint movements that involve bigger muscles, and so that kind of looks more like a squat or a sit to stand, and then you're going to want to go from there into more of the open kinetic chain single joint exercises. So if you're thinking about doing someone in the lower extremity, working with someone in the lower extremities, you're going to probably start again with squats, and then you're going to end your session more on like long arc quad or knee extensions, whatever you want to call them, because that would be the textbook or literature referenced way of exercise order. And so again, it's a Walgreens world. You have to know it from that level. Which one would you start with? You'd start with multi-joint, bigger muscle, more whole body movements, and then go down to single joint, smaller movements. And then we want to talk to you about frequency. Again, that's driven from that concept of recovery. And so recovery specific to inter-session recovery. And we tell you that optimally, and this is just like looking at a person from a physical therapy standpoint, 2 to 3 days a week for strengthening exercises or resistance exercise. And again, we're not talking about the people who do this 5 or 6 days a week. We're talking about our patients, what's best for our patient, how do you pass a licensure exam. You're going to go with 2 to 3 days a week, okay? So that's kind of our crux there. Stability does continue, specifically with isometric. We want to talk about some key things about isometric. Remember, isometric is contraction with no movement, right? And just for fun, let's talk about what was the verbal cue we used to identify isometric activity. I mean, we would say this. What was it? Right, match my resistance. And so if you use that term, what you know is that there is going to be kind of a collision between two body forces that is going to create no movement. So what's the intensity there? Well, you work it at about 60% of the MVC, and so you kind of think about what's top on that muscle. You're going to stick at most 60%. Sometimes we're going to be less, and many times we are, but 60% is kind of the optimal level. Another thing there is how long should that contraction last? 6 to 10 seconds is what we're going to tell you. And so then we have to know, is there a precaution there? And I'm thinking about this almost like I'm holding my breath, right? What does that mean? It means Valsalva. So we're shutting the epiglottis over the glottis, and we're compressing down. We're creating a lot of pressure, which causes a big spike in blood pressure. And so that is Valsalva, cut and dry. Now, there's a lot of other variables that go into it, and you kind of can think about that, but definitely you need to know that is a precaution. And then you need to know what Valsalva maneuver is. I'm going to hit you on at least one, if not more, questions that are going to concern that. But again, remember breath holding as your key term for understanding Valsalva. Let's talk about concentric and eccentric. So with concentric and eccentric, we are phasing out of isometric, going to isotonic, but let's just kind of, for a better terminology from my perspective, let's talk about it as dynamic constant external resistance. That's what you're seeing on your screen right now, DCER. And so with that, what are we doing? We're saying it's a dynamic, means there's movement. It's not static like isometric, and it's constant external resistance. And so what you have to understand is that you're having that resistance throughout the range on one muscle. So think about the bicep. The bicep flexes the elbow, but the bicep has to control the elbow as it goes into extension if there's load. And that's the key thing you have to remember, right? So what was the verbal cue there? Well, for concentric, it was basically you're going to pull up and I'm going to resist you. But for eccentric, it was resist me but let me win. And so you think about how those concepts come in, and all of a sudden now you're like, okay, it's a dynamic, moving, constant external resistance on one muscle, just one muscle, just one muscle. Think about that really nasty question that many of you got really fussy with me about, where you would take the TheraBand and you would externally rotate, right? And some of you were like, man, which muscle did concentric, which muscle did eccentric? Well, that's not the way you approach it. One muscle does both, right? And that's your external rotators, because your external rotators, what they do, they externally rotate it, so there was concentric, but then they also had to eccentrically decelerate that movement. Otherwise, you would have bloodied your knuckles because the rubber band would have just pulled you together. And so you kind of have to think about it, apply it, and then go in and attack that question. What do we have on open kinetic and closed kinetic chain exercises? Well, so one of the things that really comes into mind is it a fixed segment or is it a free segment? And that is honestly one of the best ways I can really tell you to look at this. I don't want you to think that we're going to debate and ask you questions over is a pull-up, a open or a closed kinetic chain. I'm not going to do that. I really kind of want you to be more firm in understanding fixed and free segment, which is a characteristic of those exercises. I also want you to kind of think about some of the unique aspects on, and I'm trying to find you the page number, on both open and closed kinetic chain as to what their benefits are. And so this was kind of a really specific thing that we looked at, and it was on page 198, actually kind of started on 199. But we talked about, isolating a muscle group. Well, that's an open kinetic chain thing. What about controlling movements? And then we talked about joint approximation and what really matters there, and that's definitely a closed kinetic chain thing. And then as well as co-activation. And so you're going to kind of look at those on 198 and just kind of remind yourself, but then also kind of think about what proprioception and neuromuscular control and balance really kind of come into. But these were all very unique things throughout that chapter that were discussed, and so you'll need to review those. And then lastly, or not lastly, but let's also look at overtraining and overwork. So overtraining and overwork sound like they're the same thing, but they're not. Overtraining is someone who's very active, and what they have done is they've kind of gotten themselves into a chronic fatigue because they're doing too much activity. But where overwork, this is kind of where you're going to stop seeing good benefits of exercise and actually get a reversal of that, where people are going to start degrading because of exercise. But it's almost always cued into like a neurogenic disease or possibly spinal cord injury type patient. But I'm thinking of multiple sclerosis here. You can overwork them very quickly. But overtraining, this is someone who's already very active and they're doing too much and they're seeing some negative effects from that. What about DOMS, delayed onset muscle soreness? We see DOMS and we say, okay, what is it? It's something that's going to happen after exercise, especially intense exercise, and especially after eccentric exercise. And you'll probably remember that we talked a lot about eccentric exercise and how strong of a DOMS case can occur there. When does it peak? Usually, 24 to 48 hours it's going to peak and then start getting better. Is there anything we can do about it? Well, you can try to throw the whole sink at it of, ice and tens and heat and all these things. But what we know is a little bit of gentle, active movement is best for domes. And so those are kind of some key things, some key takeaways on both the domes concept, but just all in general on stability. All right, so now we move into chapter 7, where we talked about aerobic conditioning. With this one, you really want to kind of think about the key terms from bioenergetics, which was ATP-PC, glycolysis, and oxidative phosphorylation. And what was bioenergetics? Well, simply put, it is the system that the body will choose to fund the activity it's going to do, right? So let me say it this way. If you're going to do something that's going to require a very little amount of movement time, but maybe some pretty good intensity, and I'm going to say like you standing up from your chair, you may do it once, but you need fuel ready to go to fund that activity, and that is in the muscle, and it's in the form of ATP-PC. If an activity is going to take less than about 10 seconds, then ATP-PC is going to fund it. If it's going to go beyond that, upwards to 2 to 3 minutes, what the book will tell us is it's going to need kind of a carbohydrate-based source to fund it. And that's going to come from the muscles, and if it continues for a long time, it's going to come from the liver. But that is in the form of glycolysis or glucose, and so it will travel through the blood into those muscles. We'll kind of get into diabetes later, so don't get those two confused, but we will kind of come back to that later in another class. From the next standpoint, if you're going to continue this activity, you're going to go walk, for let's say 30 minutes. You're going to need an energy source that's more long-term, long-lasting, and you're going to pull it out of storage. And our greatest storage energy is fat, and that's where oxidative phosphorylation comes in. It's going to use oxygen to oxidize fat molecules and then fund that energy. Where glycolysis and ATP-PC, they're both anaerobic. They don't need oxygen. They're getting their energy sources from somewhere else. We want you to know kind of from a standpoint of fitness testing what we're looking at here, and so we had you do a 1 mile walk test, right? So that's fitness testing. The 6-minute walk test is fitness testing. It's understanding how much a person can do within a specified amount of time. Another fitness test that is often used is stress testing, which is where we take a patient, we put them on a stationary bike or a treadmill, and then we hook them up to a 12-lead EKG. And then we see how they do, and we're looking for angina, and if so, are there any other electrical abnormalities that we can kind of find from doing this stress testing. And if they do have angina, then we terminate the test, or they do have some really unique electrical abnormalities, and we terminate the test. But those are kind of some things about stress testing that you really need to know going past their X1. What are some physiological responses that do occur with aerobic conditioning? Well, this is like you take off, you go out your door, you go on a run. What do you expect to see? Well, cardiac-wise, we expect that most people will have an elevated heart rate. Now, that's going to be different based off of your fitness, and we'll kind of go into adaptations here in a second, but we know that your heart rate's going to go up. We also know that you're going to have a pressor response, and pressor is just kind of a really flashy word to kind of describe pressure, and you know this as blood pressure. And so we're going to see an increase in blood pressure. Now, it's really critical for the PTA to know that they can expect a systolic increase in blood pressure that's probably pretty substantial. Like, I don't want to put a percentage on that, but you might see it go from 120 to 150, 160, 180, and that's normal. It's when a diastolic pressure goes up or down pretty much over 10 points. That's when we start kind of worrying, because the diastolic pressure, that's your resting pressure, it really shouldn't change much. You will see some change, typically in the upside, but not much. And again, just look at it from the perspective of about 10. And then just kind of throwing this back at you, what is a threshold that we need to monitor and say this is where blood pressure has gotten and we're not going to let it go any further. We're going to terminate whatever activity we're doing. If that's the case, we're looking at a number 210 over 110. That's our threshold. We don't want our patients to go above that. If they are, they're really kind of getting into a danger zone of stroke. And so we're going to just terminate whatever treatment we're doing, especially activity-wise. What about respiration? Well, again, as you know, your respiration rate's going to go up. What's it normally? 12 to 20. So if they go into a tachypnea type situation, don't freak out. It's just normal responses from aerobic conditioning. And if you've ever taken off on a walk or a run, you know this. Your breathing rate goes up, right? Your respiration rate goes up. So it's normal. It's just, what is abnormal? Well, when a person leaves tachypnea and they start to hyperventilate, they're probably at an excess rate of 30 to 40 breaths per minute or higher. And so we kind of understand that that's just kind of a number out there, and it's very dependent on the situation, but also their comorbidities. So just kind of understand that respiration rate will go up. Let's talk about what frequency of aerobic conditioning should look like. The American Heart Association, American College of Sports Medicine, all those people, they said, listen, 3 to 5 days a week, more is almost often better. So, like if you see 6, choose 6 because it's more than 3 to 5. But, if they have other issues, then you might back that off. But 3 to 5 or more is optimal. What about volume? Well, 20 to 60 minutes is kind of what we learned from our slide in aerobic conditioning, and so we're going to kind of continue to press upon you. 20 to 60 minutes is the right volume. But what about intensity? Well, intensity determines volume, and often it also determines frequency. But let's just kind of focus on volume for a minute. So for instance, what we know is for the young healthy person to see a stimulus threshold be met, and that is like minimal stimulus threshold, like what they have to do just to get a training response, is they have to hit around 70% of their age-adjusted max heart rate. So that's MHR, and that's 220 minus age, and it determines a number. You're not trying to get to that number, you're trying to get to 70% of that number. And so rewind this, watch that again, and make sure you catch that very clearly. That is also known as your target heart rate. Target heart rate is taken from max heart rate. So again, you take your age, you subtract it from 220, and then you take 70% of that, and that's kind of where you have to hit if you're young and healthy. Now, if you're not young and healthy, maybe you're starting out. We're going to start you at around 60%. And that's where we're going to go. But what if you have like cardiovascular history, or you've been in the hospital bed for a long time? Well, we're going to start you out at even less than that. We're going to go around 40 to 50%. That's your new target heart rate to start with. But if you're young and healthy, we're going to start you at 70%. If you're young and healthy but you just haven't been doing anything, we're going to start you at 60%. And then if you're really in a bad spot, then we're going to take you down to 40 to 50%. But that's because you have health, heart, other issues that you've just been down for a while on. Let's talk about Borg scale, and there are two, right? So you have your 20-point scale, or your 14-point scale, sorry, and you have your 10-point scale. On your 14-point scale, what we're looking there for is the same thing we're looking at the 10-point scale. Are they working at somewhat hard? That's kind of a threshold that you just have to make friends with. You have to know, what does somewhat hard mean? Well, somewhat hard is a key thing that is located numerically at 13 out of 20 on the 14-point scale, and it's 4 out of 10 on the 10-point scale. And again, what is that 14-point scale? Well, it does go from 6 to 20. On a 10-point scale, it's 0 to 10. And so you just really want to keep up with what are those terms and what do they mean. How about our METs? Well, our METs kind of come in and they say we need to be light, moderate, vigorous. And so with METs, very specifically what we're looking at here is the idea that you have a specific output of oxygen that is, or input of oxygen you're going to need to be able to fund this activity. So if you're doing a very light activity, that's 0 to 3. A moderate activity is 3 to 6, and a vigorous activity is anything above 6. I'm gonna let you go back and look in the slides to kind of get some examples of those, but just kind of make sure you're aware of what those are. What is a warm-up? Well, we gave you 4 specific distinct things about a warm-up. Number 1 is it is dynamic. What does that mean? It's not static. Static stretching is static. That's something you do for a cool down, but it's not what you do for a warm-up. Another thing is it's physiological, meaning you actually see a body temperature increase, right? And then a third thing there is it does have a time component. We want to go from 5 to 10 minutes to do our warm-up for aerobic activity. And then lastly, we do want to understand what the heart rate criteria is for that. And that is very specifically, do you know that it should be at about 20 beats per minute away from the target heart rate, right? So if your target heart rate is, let's just say 135, your warm-up should get you roughly to 115 before you start your activity. That's, again, it's Walgreens world. That's optimal, right? It doesn't happen in every clinical case, but it is best. Now we want to talk about what adaptations are going to occur. And this is almost exclusive to the cardiovascular adaptations. So what happens after doing aerobic conditioning for, several weeks? And so number 1, how many weeks does it take? Well, what we did was we said back in the adaptations of hypertrophy, we said that took 4 to 6 weeks before you'd see hypertrophy. Remember, the first 4 to 6 weeks were all neuro. And I know I'm mixing this up a little bit. It's just to keep you on your toes. But what we know about aerobic conditioning is this thing isn't going to happen for upwards to 10 to 12 weeks. That's what the book tells us. And so we kind of see it kind of migrate over, and it takes a little bit longer. But at 10 to 12 weeks, you're going to see some adaptations. Number 1, you're going to see your heart rate go down. Your resting heart rate's going to go down because it's not having to work as hard to pump blood. So that's a good adaptation. So we're going to see a better heart rate. They're going to get closer to that 60, less likely they're going to be at 90, right? And then we're going to see an improved blood pressure. And so that's only in people who are hypertensive. What does that word mean? They have high blood pressure. We're going to see their blood pressure get better. If you already have good blood pressure, it's not going to take it lower. It's just going to help you sustain that for better time or longer time in your life. Now, there is one area here that we didn't include, and so I'm going to go ahead and just kind of punch this in on this slide, and that is what are our aerobic workouts. And just kind of keep this in mind. So we have aerobic workouts that are known as continuous. And with a continuous workout, what are you doing? You're basically just jumping out there and you're running for a continuous 20 to 60 minutes, or you're biking for 20 to 60 minutes, or you're swimming, or you're walking. Big dynamic movements for 20 to 60 minutes. There is kind of another type of workout that we call interval. An interval, again, what does that word mean? It means rest. And so you're going to do a little bit of workout, but you're going to have a scheduled break. So you might go run a really fast lap at the track, and then you might rest for 5 minutes, and then you might repeat it. So that is known as an interval workout, right? And then you had one more, and that was known as a circuit workout. And the circuit workouts, remember, they go to stations. Like they have station 1, which is jump and jack. Station 2, which is push-up. Station 3, which is air squat. Station 4, which is burpee. Station 5, which is jump rope. And then station 6 is a rest station. But again, it's still a station. I agree there's some confusion that could come in if there's a rest station, because you're like, well, isn't that an interval? Well, yeah, you could make the argument. But let's just kind of keep these things simple. If you have a scheduled rest, we're just going to call it an interval. If you have stations, we're going to call it a circuit. And if you have a circuit that has a rest station, we're going to call it a circuit interval. How about that? Let's just really make it nasty. But just kind of keep these three in line, and let's just make this simple to understand what those workouts are, right? So then we're going to move into slide number 8, and this is all about balance. And what we want you to understand is that balance has 3 systems. That's visual, vestibular, and somatosensory. You need to be able to understand what those 3 systems are, how you can eliminate those, and and then understanding that when you eliminate those, the other two, if you eliminate one of those, the other two have to respond at a higher level. And that's kind of what we do with therapy. And we want you to challenge your patients by eliminating each one of those individually, and sometimes in duplicate, so that you get an uptick or an upgrade in the other systems. What about strategies? Well, the strategies were ankle, hip, weight shift, suspension, and stepping. And so those were things that we would do depending on a perturbation, how we would adjust and regain balance. So let's kind of remember what those are. Let's remember kind of the way the muscles will have to contract. For example, if it's an ankle strategy, you're going to see more of a distal to proximal a distal to proximal muscle contraction, whether that be from a posterior perturbation or an anterior perturbation is depending on what side, right? But you need to know it's a distal to proximal. It's a small perturbation. If it's a big perturbation, then it's going to get the hips. Same thing, sagittal plane, but different muscles. And it's actually going to go proximal to distal at that point because it was a bigger perturbation. And then we also want to understand, again, and you know this, the lifting is very specific here. If they have balance quad problems, then we're going to advise them to do a stoop lift, not a squat lift. We also know that there's two very unique things called anticipatory balance and reactive balance. And so look, we're going to keep this really simple too. Anticipatory balance means you see it coming, so you're going to have to deal with it. That could be in the form of a balloon that's coming towards you and you're going to tap it, all the way to you're standing and you're going to step and then back to floor, step and back to floor. That's anticipatory. You're having to look and see where the step is and put your foot on it and back down. It could mean that you're standing in the middle of a circle of cones and you're leaning down to touch a cone. You anticipate it, you're thinking about it, you're moving down to it. But what's different is in reactive balance. Reactive balance means that there was a perturbation placed upon you, meaning someone pushed or pulled you perhaps, or maybe the wind blew really hard and it shifted you over, and to deal with that you might have had to do a suspension strategy or a stepping strategy, right? But you had to deal with that as a reaction, and so you want to just keep those two terms very clear. One other thing that we're going to look at is static balance versus dynamic balance. And again, static is no movement, dynamic is movement. And so we want you to understand we apply those many times to the base of support. If they have a stable base of support, it's static. If they have an unstable base of support, it's dynamic. And so what's an unstable base of support? Well, it's a foam pad, it's a mini trampoline, it's a roller, it's a Bosu ball, right? But what's static? What's stable? Well, that's the floor. That's the floor. That's a really stable chair, right? And knowing that that's standing or seated. Please make sure you kind of look at these topics and understand what it is that we're looking for these. Also, remember, there was a medication question in balance. I didn't put that in here, but I bet you can remember it and jump in there and grab it. Let's talk about posture real fast. What are the compressive forces on the spine? Go back to your Kines book. Go back to our slide. Look at those compressive forces on the spine. What does it look like in supine, side lying, standing, sitting, leaning forward with a load, standing, leaning forward with a load, right? You need to know what is least to greatest, and you have to have a working knowledge of this, because you're not going to get away from this, because they are so very unique, right? Because standing is less than sitting, and so we want you to have a very good working knowledge of that. In fact, I think I'll go ahead and stand right now, right? So if I stand from my seated position, what am I doing? Well, I am decreasing the compressive forces on my spine, right? And so we do that very dramatically so you see it, and you can kind of implant that in your head. But what if I lean forward while I'm standing? Well, that increases it. What if I sit down? Well, that's going to increase it. What if I put a load and sit down? That's going to increase it. But what if I lie on my back, supine? Well, that's going to really decrease it. And so you need to have that working knowledge of what is a compressive force on the spine and how do we deal with it. What about those spondies? Go back and look at those and think about the reference I made. So RA is spondylitis, and that again is RA of the vertebral body, or that anterior pillar. OA of the anterior pillar is known as spondylosis. If you go much past that, you're going to start talking about fractures, and they're going to be at the posterior pillar, specifically at the pars interarticularis. And what we're talking about is a single fracture is a spondylolysis, bilateral fracture is spondylolisthesis, and we see an anterior shift. Again, look at the length of the words, look at the suffix, prefix of the words, or just look at the suffix. You don't have to look at the prefix. Prefix is all the same, but the suffix definitely changes things. Itis is true inflammation, so that's RA. Osis is OA. Lolysis is a unilateral fracture. Spondylolisthesis, that's a bilateral fracture, anterior slippage. What about the plumb bob alignment? I've encouraged you to think about Earl and Linda got pillows alike, but if you have a better one, go for it. I did see that in some of your testing questions, this was a little bit of a struggle. Think about that earlobe, going to the acromion, going to the lumbar bodies, going to the greater trochanter, posterior to the patella, anterior to the ankle or malleolus. So just remember that, and that's like optimal. It's not what we're going to see in every person. In fact, we're not going to see that in a lot of people. But the book wants you to know, and the test wants you to know, and the licensure exam is going to want you to know how to look at what should be versus what is. What about global muscles and their characteristics? Well, remember from chapter 9, we really looked into some things about global muscles as well as the segmental muscles. And actually, I'm sorry, I said chapter 9. That was not true. This is in chapter 14. But one of the things that we know is that a global muscle is there as a guy wire, and it's there for big movement, and it does a lot of compressive forces over the spine. But one thing that we know is that it doesn't stabilize the spine at every segment. In fact, it goes across many spinal segments or vertebrae. And that's part of global muscles. And a great example of that was your upper traps, or maybe it was your erector spinae muscles, or maybe it was your quadratus lumborum, right? And that's kind of what we know were some of the big global muscles. And you can find a really good table 14.1 on page 423 that talks about this. And then it talked about in the cervical spine, the sternocleidomastoids, the scalenes, levator scapula, upper traps, and erector spinae, all being global muscles. So make sure you're kind of familiar with what a global muscle is. This is definitely testing you on your anatomy, right? What about those deep segmental muscles? What were they? Well, these were muscles that went from vertebrae segment to vertebrae segment. I mean, like from C1 to C2, from C2 to C3, from L1 to L2, L2 to L3, right? And they were very small. And the one that I really kind of leaned on you about was the multifidus in the lumbar spine. That goes all the way up too. But also think about things like the transverse abdominis. And again, that's that big corset muscle in your lumbar spine. Think about up at the cervical spine, muscles like the rectus capitis or the longus coli. Those were the big ones that we talked about. But definitely they're unique because we didn't really hear a lot about those muscles. They're very small. What do? They go from vertebrae to vertebrae. So we want to make sure that we understand those. And then we want to talk about how do we activate those muscles. Well, for the lumbar spine, we did a drawing in maneuver. For the cervical spine, we did a chin tuck, right? Those were small muscle movements, and they really matter to us, and we're going to use those as we begin Therex 2. And so we kind of looked at those throughout chapter 14, and then we understood, again, what we're going to do with those as we go forward. Let's now kind of get into just some last things here, and this is all out of your kinesiology textbook. This is looking at key terminologies from normal gait. And so again, that's like, understanding double leg support, single leg support, float phase even, all just kind of being key terminologies. But then we got very specific with terminology, and we went to traditional terminology. And so stance phase, swing phase all had very unique things when it was traditional. This is starting at like heel strike and it's going into foot flat, and then it's going into mid stance, and then it's going into heel off, and then it's going into toe off. And that's when you started an acceleration, mid swing, and then a deceleration. So those are all anatomical terms that describe the gait cycle of traditional terminology. For RLA, it was very different. And remember, this started from a temporal or timing thing. So it was it was initial contact, it was loading response, it was mid stance. And then what we did was we saw kind of heel off converge into some new terminology where we saw this very unique thing called terminal stance, which went into pre-swing, and then pre-swing went into mid-swing, and mid-swing went into terminal swing. And so those are just some key things that you need to understand about the differences between traditional versus RLA. And then we looked at peak muscle activity. I could probably do a whole video over peak muscle activity and peak range of motion, but we gave you some key things there, and we want you to know about what those are at the hip, the knee, and the ankle, but also at the pelvis. Think about peak range of motion of what the pelvis should do, and it's 4 degrees forward, 4 degrees backwards for a total of 8. What about toe out? Toe out should be around 7 degrees. And then what about vertical displacement? About 2 inches. And then we had a horizontal displacement too at about 2 inches. So we want to keep those things going and consider what we're looking at there. We also want to remember abnormal gait. And remember, there's 4 reasons for abnormal gait. You have pain, you have weakness or paralysis, you have range of motion limitations, which is either a contracture or it's a fusion, and then you had neurological involvement. Those were the top 4 things that we saw for abnormal gait, and then we gave you specifics about those. And then we even included, some very technical terms like circumduction and vaulting. We talked about some things that were very specific to some, and you want to go back and you want to review those and understand what abnormal gait looks like, right? Okay, so there it is. I'm trying to keep this under an hour, so you guys might watch it, but kind of go through there, consider that. Make sure you took that Kahoot. It's still available and it's ready for you, and that will help you too to see a lot. 50 questions coming at you on the final. I know you're going to do great. We'll see you soon.